Hello, good morning, everyone, and welcome to our Sickle Cell Data Collection Program for California's webinar series. I'm Yanni Kofer, and I'm from tracking California's SCDC program, and I'll be today's moderator. We have a great webinar planned for you today focused on findings from SCD on COVID and sickle cell disease.
I'm excited to hear both the presentations today and hear them because I was initially going to give a talk about this work, but really Sarah Reeves and the Michigan team have been the main drivers of this work. And Sarah offered to share her slides for a presentation that she had given earlier with me to draw some bits from my presentation. But Sarah's slides were just perfect and amazing and probably much clearer than anything I could have done. And Sarah was available and willing to present this work, and I'm really excited to turn it over to her. This is really her story, a Michigan story to tell, and I'm thrilled that she'll be able to do that. And Sarah, maybe you could just give that one or two sentences about who you are, and then jump into it.
Sure, I'm happy to. Can everyone hear me okay?
We can.
Great. So thanks, Susan. I'm excited to talk about this. So I'm an assistant professor in pediatrics and epidemiology at the University of Michigan, and I have had the great excitement of being able to, over the last couple of years, be the PI of the Michigan SCDC program and learn from Susan and Angie and Mary and all the others on this call also. So I appreciate the invitation to talk about this, and I'm looking forward to it. You can go to the next slide. Great. So with everything that we do in SCDC, obviously, there's a lot of collaborators, and each one is important. Work couldn't happen without it. On the Michigan side, our SCDC program is a partnership with the University of Michigan, which is where I'm at, and Kevin Domkowski and Crystal Latta. And then the collaborators at MDHHS, which include Dominic Smith, Mary Klein, Isabel Hurd, and Shannon Johnson, and Tiffany Henderson. You'll see as this goes on that this analysis is replicated both in Michigan and in Georgia. So our Georgia partners are listed there, and as always, our support from Mary Houlihan in thinking about how to make this most relevant going forward. We also, this paper is under review right now, and we had technical assistance in contributing authors that you can see there. Next slide, please. So I do not need to tell this group this, but just in terms of level setting, sickle cell disease is associated with many complications and early death. And a lot of this results in hospitalizations, emergency department visits, outpatient visits, cost. And then what's important to think, the important fact about sickle cell to know going into this talk is that all states screen for a variety of different genetic disorders in which early detection can be really helpful in saving lives, and that's called newborn screening. And sickle cell disease is one of the conditions that all states screen for. So this means that everyone with sickle cell disease is identified at birth. Next slide, please. And then this also is not something I need to tell this group, but I would be remiss not to very explicitly say, especially given the findings of this study, that sickle cell disease is a challenge to manage for anyone, and it's further complicated when we consider the structural and institutional racism in the United States. Next slide, please. I put this slide, I try to put this slide in most presentations where I very explicitly say that the majority of people living with sickle cell disease in the United States are Black and consequently face racism and discrimination within and outside of the healthcare system. And this can obviously have a lot of impacts on health. So moving on to sickle cell trait. Sickle cell trait is the carrier condition of sickle cell disease. And it's a lot more common than sickle cell disease. Approximately 8% of Black births are identified as having sickle cell trait. It's also a condition that's in newborn screening, so everyone with sickle cell trait is identified at birth. It is considered generally benign, and I underline generally specifically because there is research showing that in very stressful situations that it maybe isn't so benign. For example, a football player with sickle cell trait that was playing football in Denver at a high altitude his spleen ruptured and was found out to be related to sickle cell trait. And, when there's dehydration or other very stressful situations on the body, it can be not as benign as previously thought. And then the other fact to know about this, and this is setting the stage for why we did this study the way that we did this study, about 80% of adults do not know that they have sickle cell trait. So even though it is identified at birth, really considering that it's considered generally benign, it really doesn't, this information may not get passed along across the lifespan for one reason or another, whether it's, and there's also a lot of variation in how states follow up for sickle cell trait results. Next slide. So now that we set the stage on sickle cell disease and sickle cell trait, what about COVID-19? Why were we interested in this? So sickle cell disease is designated by the CDC as a high-risk condition for poor COVID-19 outcomes. As with most things with COVID, there's not really a ton of research backing up some of these things. There's definitely expert opinions and things like that, but in terms of methodologically rigorous research, there's not a lot. So, but the early research that's been coming out, there's some conflicting results. Is it or is not? Is it a high-risk condition for poor outcomes? Low sample sizes, very targeted samples. Next slide. And also, sickle cell trait, there are some opinions that sickle cell trait could be a high-risk condition. Because when you think of COVID-19 and the different clinical outcomes there, renal impairment, dehydration, COVID-19 can be a really high risk or high stress situation on the body. And so it's likely that it could be related also to COVID-19 poor outcomes, even though it's generally a more benign condition than sickle cell disease. Again, early research did not have great methodology for case ascertainment and was not population-based. So it's hard to figure out, but it's considering that sickle cell trait occurs in approximately 8% of Black births in the United States, if sickle cell trait actually is a high risk or an indicator for high risk for poor COVID-19 outcomes, it could be contributing to some of the racial disparities that we see in COVID-19 outcomes. Next slide. So the objective of this study was to assess COVID-19 outcomes, specifically hospitalization and mortality, among people with sickle cell disease and sickle cell trait in Michigan and Georgia. I'm really specifically going to talk about our Michigan results, just because that's what I'm a lot more familiar with, and we had a bit of a broader lifespan, but I will touch on the Georgia results at the end also. Next slide, please. So in Michigan, and MDHHS is the Michigan Department of Health and Human Services, we use newborn screening records from 1987 through 2019 for our study population. And then also we use COVID-19 infections, hospitalizations, and deaths from the Michigan Disease Surveillance System. That's where all of our COVID cases are required to be reported to in our state from March 10th, 2020 through November 30th, 2021. We cut it off very adamantly at November 30th because after that, the Omicron wave hit, and I believe there's already plenty of underreporting with COVID, but probably got even more extreme after November 30th. So we just cut that off to have a little bit of a cleaner population. Next slide. To identify our study population, we link newborn screening records to COVID-19 results. The reason we use newborn screening records, it goes back to what I was saying, is that there's really no other way except newborn screening records to get at the population of people with sickle cell trait in these states. We link the newborn screening records to COVID-19 results. And when I say we, actually it was Isabel Hurton at MDHHS. She's the newborn screening epidemiologist, and the majority of all of the linkage credit, which was a heavy lift, goes to her. We used a probabilistic linkage. There was a little less data available than normal to link on, so we used name, sex, and date of birth. We excluded anyone that had a missing or abnormal newborn screen. It's not necessarily because anything bad happened or we didn't know. It could just be someone that was born out of state or it didn't match. So we wanted to make sure that our final study population was exclusively people with a known COVID infection and sickle cell disease, sickle cell trait, or normal hemoglobin. Next slide, please. Our outcomes, which we pulled from the Michigan Disease Surveillance system are hospitalization and mortality related to COVID-19. So COVID-19 hospitalization, COVID-19 mortality. Then our exposure was hemoglobin status. Again, people were in 3 mutually exclusive groups: sickle cell disease, sickle cell trait, and normal hemoglobin. And our demographics, that we pulled this from newborn screening and birth certificates whenever available. When it wasn't, we would pull it from the COVID data, and those were age, sex, race, and ethnicity. We also, in Michigan, pulled data on reinfections. And a reinfection was defined as 90 days after a previous infection. For our analysis, the first thing we looked at was the proportion of people in our study population with COVID-19 hospitalization and then COVID-19 mortality by hemoglobin status. So again, sickle cell disease, sickle cell trait, normal hemoglobin. Then we looked at the associations between hemoglobin status and COVID-19 hospitalization and mortality using logistic regression with generalized estimating equations. And the reason we use generalized estimating equations is because people could contribute multiple infections, and we wanted to make sure to account for that. Obviously, we did not use generalized estimating equations for mortality because there would not be multiple observations that ended in COVID-19 death. We adjusted all of our models for sex and age. Secondarily, we restricted our models to Black race only, as identified in newborn screening birth certificates, to really try to get at separating the impact of sickle cell trait from race on COVID-19 outcomes, especially given that we know that there are so many disparities in outcomes by race in the United States. And for the next several slides, I must give complete credit to Krista Latta, who did this analysis with a extreme level of attention to detail and accuracy. So these are the linked newborns. There were about 650,000 COVID infections from people that were born 1987 to 2019. And again, the reason that we had to cut to that age range was because that's when newborn screening for sickle cell started in Michigan. About 40% of people did not link to newborn screening. And again, that could just mean they were born out of state or did not link for some reason. But about 60% were linked to newborn screening, which was honestly a little higher than we thought. Next slide. We excluded infections for a variety of reasons, and that was 8%, but our study population infections were about half, so 50%. So our entire study population infections were about 330,000 people. Infections. Of those infections, 245 of them were among people with sickle cell disease, just over 4,000 were sickle cell trait, and then the majority, 98%, were among people with normal hemoglobin, which, given the distribution of sickle cell disease and sickle cell trait in the population, this makes sense. Here are our demographics. The first column, sickle cell disease, and sickle cell trait, and then normal hemoglobin. You can see the number of infections at the top. And so, there are 5 reinfections in sickle cell disease, a few more in sickle cell trait and in normal hemoglobin, but really reinfections during that first time period up to November 30th was relatively rare. Obviously not so rare anymore. So I'm sure this would look different now. Our mean age, thanks. Our mean age was, just under 20, which again, our study population was really only 2 years old to 35, so that makes sense. And you can see, not surprisingly, the breakdown by race is about what we would expect, given the distribution of sickle cell disease and sickle cell trait in Michigan. Next slide, please. I'm going to walk you through our results. This is the proportion of infections with COVID-19 hospitalization and mortality by hemoglobin status. You can see on the bottom, there's normal hemoglobin, sickle cell disease, and sickle cell trait. And on the side is the proportion of infections. So there was a very low rate of hospitalization and death for normal hemoglobin. Just under 20% of people with sickle cell disease had a COVID-19 hospitalization, and about 2% had a COVID-19 death. And for sickle cell trait, just under 2% were hospitalized, with also a very low rate of mortality. Next slide. These are the results of our model. So this first section is the odds ratios and 95% confidence intervals for COVID-19 hospitalization and COVID-19 death And we compared sickle cell disease to normal hemoglobin and sickle cell trait to normal hemoglobin. So what you see here is that in people with sickle cell disease, in all these models are adjusted for sex and age, but these are among all races, that there was about 33 times higher odds of COVID hospitalization than people with normal hemoglobin for sickle cell disease, and about 25 times higher odds for death in sickle cell disease compared to normal hemoglobin. For sickle cell trait, these results were quite a bit lower, but still there was almost 3 times the odds of hospitalization and death for people with sickle cell trait as compared to people with normal hemoglobin. Next slide. When we restricted these models, restricted them to Black race only, here's the odds ratios and 95% confidence intervals. You can see that the odds of hospitalization and death in the sickle cell disease group are still significantly higher than the normal hemoglobin group, 15 times the odds. But where the story really changes is around sickle cell trait. There is, the confidence interval here crosses over 1, which means we really can't be sure that there's any difference in the odds of COVID-19 hospitalization and death for people with sickle cell trait as compared to people with normal hemoglobin. And again, this is when we restricted this to people that were identified as Black race only through newborn screening records and birth certificates. Next slide, please. Oh, sorry, there's my circles. We're comparing, so that was, you can see that these really dropped, but that they did not eliminate the association. You can go ahead to the full next thing. You don't have to worry about the circles. Thanks. So those are the results from Michigan. In Georgia, we use very similar methodologies with a few caveats, just given the restrictions and when the timing of newborn screening began. The study population in Georgia was under 12 years old, and there was no reinfection data. We did see very similar results, but smaller effect sizes in hospitalization. There was no mortality in the sickle cell disease cohort. This makes a lot of sense because this is a much younger population than what we were looking at in Michigan. And so I think having a smaller effect size actually adds some confidence in our results also. Next slide, please. So for this study, in summary, when we looked at sickle cell disease, there was significantly higher odds of COVID-19 hospitalization and mortality compared to normal hemoglobin, 15 times the odds actually, which is really significant. Next slide. But in sickle cell trait, we had a little bit of a different story. Initially, there were higher odds observed when this was among the entire population. But then after we restricted to Black race only, there was no increased odds of hospitalization and mortality compared to normal hemoglobin. And something to keep in mind here for this is that even the 15 times higher odds, this was in a young cohort. This was all people under 35 years old in Michigan. So I would anticipate that this would even look different in a older population. And just a couple points for discussion, and I know we'll do questions later so we can talk about it, but this was very methodologically rigorous. We talked about the limitations of other studies with being able to identify people with sickle cell trait in a population of sickle cell disease. And we use newborn screening records, which is really the gold standard for both for the case ascertainment of this study. This also is a really, I think, showcased the successful collaboration between the CDC, state health departments, and academic institutions. In Georgia, the state health department actually ran this data, and it was a really, I think, great way to show the collaboration that can happen across public health sectors. That's my fault. Those are out of order. We linked multiple sources of data. We linked newborn screening records to COVID-19 data, which I think is a great use of that data. And then going forward, we want to leverage our SCDC data. I know in Michigan, and I'm hopeful in Georgia too, to look at COVID-19 outcomes for sickle cell disease, so longer term outcomes. What is that looking like among this population using the population-based cohort of SCDC? Next slide. I put Michigan implications just because I have been talking about those results, but this is really across the board. This really, really emphasizes the need for vaccine uptake in people with sickle cell disease. MICR is our immunization system, and it's also population-based, and I know that's true across most of the states. So thinking about leveraging more population-based data systems to identify opportunities for improvement. And then this also brings up health equity implications for COVID-19 outcomes. When we restricted to Black race only, really the associations with sickle cell trait went away. And so, I think there's much broader implications actually for this study, even beyond sickle cell trait and sickle cell disease that we could consider. Thank you for your time. I'm happy to take questions afterwards.
Wonderful. Thank you so much, Sarah. And just as a reminder for folks, we are going to hold all questions until the end of both presentations. So, but please feel free, if you have some questions now, to go ahead and begin submitting them in either the chat box or the question function on your control panel. And so moving right along, I am honored to be able to introduce our next speaker, Brandon Attell. Brandon Attell is a senior research associate with the Blood Disorders team at the Georgia Health Policy Center. He has expertise in health services, research using a variety of administrative data sources, and enjoys using innovative methods and partnerships to link data across disparate sources to inform and improve population health. And so with that, I'll turn it over to you, Brandon.
Thank you, and thanks, Sarah, for your presentation as well. I think that does a really good setup for me in thinking a lot about the implications and connections between sickle cell disease and COVID-19. But good afternoon to everyone on the East Coast, and I guess still good morning for everyone on the West Coast. And I'm very happy to be here today presenting our study, which is trends and characteristics of emergency department utilization both before and during the COVID-19 pandemic among people living with sickle cell disease. And similar to Sarah's project, this is definitely a multi-state collaborative where we are using sickle cell disease data collection data from multiple states, Georgia, California, Michigan, and Tennessee. So I also want to give a huge acknowledgement to all of the collaborators on this study. This study is a little bit still in work in progress. We got about half of the data in for the study. And so this is very much preliminary results that we're presenting today, and we would love any feedback that you all have, and of course questions, happy to answer those at the end as well. I did want to start the presentation just by setting us in a little bit of context about overall acute care utilization across the US. And this has been a really big focus of health services researchers who study this, and they've been very interested in tracking the impact of the COVID-19 pandemic on acute care utilization. And this is an excellent, probably one of the most comprehensive studies that I've seen come out about this from CDC researchers that came out in August of this year, where they used data looking at changes in hospital utilization in more than 700 hospitals across the US. And this figure is from their appendix, and what it shows is it compares each calendar month in 2020 back to its own month in 2019, and looking across all of those 700 plus hospitals and looking at how admissions or discharges from these different settings within the hospital changed over time relative to where they were at pre-COVID. And what we see here is that by April of 2020, there was a huge drop in acute care utilization. And across a variety of hospital settings. And what I want to draw your attention to is that there wasn't the period in 2019. The chart over to, sorry, I paused because I'm getting an echo back on my voice, but I think it went away. So the emergency room utilization had not gone back to the same levels of all of the other settings that we see relative to 2019 by the end of 2020. Next slide, please. What's really interesting as well is when you stratify the change in utilization by different age groups, we pretty consistently see across observation units, same-day surgeries, and once again, emergency room or emergency department admissions, we see a consistent trend where younger individuals experience the largest drop across those settings and continue to see the lowest drop across those settings over time. One kind of exception to that is in inpatient admissions, where in April of 2020, their drop was actually the lowest, and they remain relatively the same to other age groups over time. But still, when we look at emergency room admissions for younger individuals, in this case, age 0 to 17 years of age, by 2020, they were still had not kind of gone back to the same level, even relative to other groups in the same time, or looking back to everyone's utilization in 2019. Next slide, please. So again, that was information about all patients across more than 700 hospitals in the US. And so we're obviously focusing on the influence of sickle cell disease, or trying to examine what utilization looked like for individuals living with sickle cell disease in terms of the emergency department. And as Sarah was kind of setting up in her talk, a lot of the early evidence and early studies that have come out that are concerned with people who have sickle cell disease have conflicting evidence, mainly because of these small sample sizes, single site studies, things of that nature. And there hasn't been a lot of good information about population level data for people living with sickle cell disease. So there's some mixed evidence about how much COVID-19 has actually impacted people in terms of the disease course, where there's some studies saying that this is a pretty mild disease course, and some saying this is pretty moderate to heavy. But we do know that their risk for hospitalization is as high as 7 times as that of individuals without CDC or SCD. And I think we'll need to potentially update this once Sarah's study comes out. We also know that individuals with sickle cell disease have a higher risk of COVID-19 related death from the studies that are currently published. And nearly 10% of the deaths that did occur in the sickle cell disease population as a whole during 2020 were found to be associated by COVID-19. And this was a CDC study that came out. And I do have the references at the end of the presentation. So very little is known about what exactly happened in terms of the population level for people living with sickle cell disease and their ED utilization before and during COVID-19. And we have several reasons that we can kind of speculate, and I'll talk more about those at the end after I show you all the results. So in the current study, we're trying to take a really holistic approach and look at changes in ED utilization using SCDC data from California, Georgia, Michigan, and Tennessee. And we're specifically looking at changes in utilization over time from 2019 through 2020, as well as changes that might differ between different age groups and between men and women. And in our broader study that's ongoing, we're also looking at potential changes in the reasons for those emergency department visits by looking at kind of the distribution in the cohort of diagnosis codes over time. But today, I really wanted to focus in on the preliminary data that we have from California and Georgia that's specific to the actual utilization. Next slide, please. So I did want to give a little bit of information about our methods and what we're doing. So we have information where we have linked our hospital discharge data in both states, California and Georgia, to a cohort of Medicaid enrolled individuals with sickle cell disease. And they're allowed to have 6 months of a coverage gap over the study window, which is 24 months from January 2019 through December of 2020. So we have 6,700 individuals in our study right now that kind of meet that eligibility criteria. And we are using an interrupted time series to examine changes in the rates of ED visits over time. And there's some information there. We're using a Poisson link function and offsetting the model to account for the cohort size in each state over time. And right now we're modeling states separately. And we kind of have 2 different models that we're looking at. The first one is just a linear model over time. And then the second one is a seasonally adjusted trend model, because we saw, and you'll see in the kind of slides where I have things plotted out, that there was some evidence of seasonality in terms of the visits, regardless of the time period that we're looking at. So we added Fourier terms to our linear model, which are pairs of sine and cosine waves, to account for the nonlinear aspect of time that we see in the data. And we also did allow a 1-month lag. So we actually kind of started looking at our COVID effect in April of 2020, giving some of the other broader, bigger studies focused on the population at large for everyone in the US, showing that there was an initial drop in March, but really we see the biggest drop starting in April. And we also examined change in utilization comparing pre-COVID to COVID by age and sex. So we have that information too. Next slide, please. So these are our secular models that assume just a linear trend over time. And you can see we did have more individuals in Georgia, roughly 4,500, compared to about 2,200 individuals in California that were contributing to the data. And the black points that you see there represent the actual hospital counts in this group of individuals in each state from January of 2019 all the way up to March of 2019. And you can see the solid black line is kind of what the model would predict the overall rate to be during that time. So for California, you can see that the model is predicting somewhat of a slight upward trend over time before COVID hit. And in Georgia, you see a very, very small negative trend going forward over from January 2019 to March of 2019. A slight decrease, it almost looks flat. What's interesting is that we're kind of seeing between the two different states a somewhat different story of what happened when we actually start accounting for COVID. So again, that gray area before the purple shaded area represents the lag that we're accounting for. So in both states, we saw a significant drop when April hit of 2020. But when we actually look at what happened after that, the story is a little bit different in each state. And you can see the red points represent the actual observed data that we had, so the actual number of counts of ED visits in each state over time. And you can see the model actually, so the model is predicting a small downward trend in California once COVID hits. So it's saying that we're going to be seeing a decrease in visits to fit the observed data. And then when you look on the right for Georgia, we see somewhat of the opposite story where we're seeing an actual upward trend that's being predicted based on the data. Next slide, please. This is all the same data, just imposing a different model on top of it. And so this is actually looking at our seasonally adjusted trends where we account for seasonal effects that would be happening over time. So the lines kind of become squiggly here to account for curvilinear nature of time. And it's essentially the same story because you see, again, since it's the same data, and you can see, again, for California, the model predicts somewhat of an upward trend over time had COVID not happened. And then in Georgia, it's kind of the same from the previous slide where it is looking like it should be kind of the same, but kind of slightly decrease over time. And maybe by the end of December of 2020, increase. And again, when we actually look at what happened in our data, we see two different stories here where it's slightly increasing for Georgia and then slightly decreasing for California. This model actually does work a lot better for us in terms of reducing the error that we would predict using our observed data versus what the model actually predicted. So right now, based on these two states, I think we're probably going to go with this model as we get more data in, but we'll definitely have to see how things look in the two other states as well. Next slide, please. So the next few slides that I have are all bar charts, and this is looking at changes in the ED utilization as a percentage relative to the same time in the previous year. So we're specifically taking March through December of 2020 and comparing it to March through December of 2019 for all of these groups in each state. And so the blue bars represent the 2019 data, and then the green bars represent during COVID during 2020. And so what's kind of interesting here is that we're seeing a similar pattern to the other study that I was talking about earlier, where we see the biggest decreases in utilization amongst the youngest individuals in the cohort. So you can see in California and Georgia, the amount of ED visits over time dropped 61% and 58% in our youngest age group there. And then followed by that, you can see kind of a similar pattern again. The other study looked at 0, I think it was 0 to 19 in the same bucket, and we have them split out here to be a little bit more granular. But we can see in Georgia about a third decrease in visits amongst those who are 10 to 19. In the middle age group, changes or these drops are not as drastic. So you see in Georgia 4% and then 7% when we look at the 20 to 29 and 30 to 39. And then in California, 13% and 6% respectively. What's interesting is if we look at the other end of the age spectrum for those who are 60 plus in our cohorts, we see in both states about a 39% drop. So youngest people experiencing the greatest drop in utilization, and also those who are 60 plus. Next slide, please. This is looking at changes in the number of visits by between men and women. And there's not as big of a difference in California between men and women. So a 15% drop in the number of visits for men and a 16% drop for women. In Georgia, we do see a little bit more pronounced of a difference where women decreased by 16% relative to 2019, and then men dropped by 24%. Next slide. This is still looking at changes in utilization over time by age, but this time, instead of looking at the overall number of visits across everyone, we're looking at changes in the number of individuals with one or more visits. So this is looking at utilization kind of at the person level and not just all visits overall. And we still see, again, with the youngest age groups, the biggest drop. So over half in California who are 0 to 9. Decrease in utilization, and then 40% in Georgia. And then when we again look at the next age group, 34% in Georgia and 22% in California. Next slide, please. And again, this is the same information looking at differences between men and women as before, but again, now shifting to looking at the number of individuals who had one or more visits. And we see there's a little bit more pronounced of a difference this time when we look at it this way in California. So here, women decreased by 23% in their utilization and men 26%. And then in Georgia, a 5% difference between men and women, where women dropped 24% and then men dropped 29%. Next slide, please. So high-level summary here is that when we look at the kind of patterns that we're seeing over time, we see that both California and Georgia experienced a significant immediate drop in April of 2020 when we really started trying to look at the effect of the pandemic on ED utilization. But we do see, if you want to think about kind of recovery in the sense of how did services get back to where they were at compared relative to pre-COVID times, this did look different in each state. But we did see in both states that younger individuals experienced a greater decrease in utilization, followed by those who were 60 plus. And we have kind of speculated based on some of the studies that are out there why some of these things might be happening. And so some of the things that we do know is that early social distancing guidelines that were from the CDC and public health departments locally and at the state level did urge individuals with sickle cell disease to stay at home except for under emergency situations. So that may have impacted why they were coming to the ED. And there are some qualitative studies out there that have been published indicating that some individuals with sickle cell disease actively avoided the emergency department out of fear of acquiring COVID-19, specifically in that setting. We also know that given the pandemic, individuals with sickle cell disease may have avoided or even delayed visiting the emergency department by trying to self-manage their symptoms or pain crises that they were experiencing at home. And this is especially true given that so many health systems transition to very rapidly increasing the utilization of telehealth services throughout the pandemic. So it may be the case that instead of going to the emergency department, they were able to get a visit through a telehealth platform instead. And we also know historically that people living with sickle cell disease have had very poor and negative experiences with healthcare professionals in the emergency department. And combined with all of the challenges that the pandemic brought, this may have resulted in lower utilization, particular to this healthcare setting. Next slide. Here are the references from some of those earlier studies about COVID-19 and sickle cell disease. And kind of where we're at now with this study is we are waiting on data to come in from all of the states, and we're going to kind of revisit these trends and continue to look at these visits across all 4 states and think about the best way to compile them. And so we'll certainly love to hear any feedback or questions or comments that folks have. And happy to turn it back over to you, Niani.
Okay, wonderful. Thank you so much, Brandon. Both Brandon and Sarah, your presentations were extremely informative and insightful and kind of raising some questions. So as mentioned before, this time we will take questions through either the question function on the control panel of this webinar or the chat box. And I will turn it over to Jackie to facilitate that process. Jackie?
Thank you, Niani. So while we wait for any questions to come in, I'll just maybe, thank both presenters for kind of giving us the description of their studies. I think they're really interesting to hear. And I want to maybe start with Sarah. It was really great to hear how your study really worked with the Department of Public Health and the Sickle Cell Data Collection Program and CDC and how successful that was. And I'm curious if there are plans. You mentioned vaccine data, to kind of link some of the vaccine data to your data that you have and to look at maybe how that may have impacted some of the outcomes or severity of COVID-19.
Sure, Jackie, I think that's a great question. There's, as with everything, probably several questions wrapped up in that we need to think about, right? So first off, how often are people with sickle cell disease being vaccinated against COVID-19, both initiating and completing? And we're working with our immunization system right now in Michigan to assess that. It's looking, our preliminary results are showing that it's very suboptimal vaccine uptake. So that brings up a whole set of questions around, outreach and vaccination messaging. So that's one. And then also thinking about when we look at COVID-19 outcomes in people with sickle cell disease long term, does vaccination and when that vaccination was received modify what those outcomes look like? And I think that could be really valuable information in thinking about how to enhance messaging around vaccination for people with sickle cell disease, but chronic conditions in general also. So yeah, we're planning to, we've already linked to our immunization system, and then we'll continue to start working on some of the nuances of those outcomes also.
That's great. I'm excited to hear more about that. We do have a question from you that was asking whether you were able to separate your population by genotype of sickle cell disease.
We didn't for this study. I'll have to look in. We could have done it, but our numbers were getting so small. They were already pretty small that we didn't have any real confidence in the results that we were getting. So I think it would be pretty hard. We could maybe do sickle cell anemia and pull sickle cell anemia out, but everything else I would get really worried about how small the cell sizes were for doing any comparisons.
Great, thank you. There was a question here for Brandon, and the question is, how can the study about ED utilization help inform healthcare practice and policy moving forward, specifically beyond the COVID-19 pandemic?
Thanks, Mary. So I think we've been thinking about that as we've seen the preliminary results come in. And one of the things that we've done is look at, maybe I didn't present it here since everything's preliminary, but we've been looking at changes in the distribution of the diagnoses associated with the visits. And what we're finding right now is that really the distribution of why people were coming to the hospital ED, or what their discharge diagnosis code was, for the most part stayed the same between 2019 and 2020. And again, we're following the same group or same cohort of people over time in each state for this study. And so I think that raises a lot of concern about, because we see such a drop in both states, where exactly did their care go and what happened to them? And I think one thing that this study has a lot of implications for in terms of thinking about practice is if these people were still having kind of the same, pain episodes or complications from sickle cell disease, and they didn't go to where they were going before, that either potentially meant that they were getting care somewhere else or potentially not receiving the appropriate treatment. And so it would be interesting to see if we could somehow try to look into, was there an actual delay in care, and did people who delay care actually have worse outcomes that may be built up later on as a result of that. And I think on kind of the flip side of that is it could potentially be that the pandemic brought out a new way of healthcare delivery through telehealth. And if it is the case, potentially, that people kind of switch to using telehealth instead of going to the emergency department from a policy perspective, is that a good way to deliver care instead of having people go to the emergency department if we didn't see any adverse consequences of that? So that's something that I think that this study could have some serious implications for healthcare practice and policy when we think, beyond COVID-19 and what happened, and has care and health services utilization returned to what it once was and in the same modalities and all of that. So definitely things that we're considering, and hopefully more to come on that.
Thank you, Brandon. One more question on yours. What, if you had to hypothesize why the differences in California and Georgia, like why they're so different from each other, what would you kind of guess that was happening there?
That is where I honestly do not have a good answer to that question. But if anyone on the call does have any hypotheses or knows more, I think it could specifically be maybe differences in how states were responding. I know Georgia was hit with COVID a little bit later than California was, at least in the kind of the initial onset. So there could potentially be differences in terms of how public health departments and hospital systems were responding in each state over time. Maybe it could be one reason that I've thought about in my mind, but I don't know a good way to actually get at that in our data. So that's one thing that I've thought of. But if folks have other ideas, and again, I think we'll have to also keep thinking about this as we get the Michigan and Tennessee data. And it's a very good question, because not only is it a question that goes towards interpretation of the results, but also has some implication for if we pull the data together, or if we're going to have to do more of a kind of qualitative, if you will, assessment of these trends in each state. So it's definitely something that's on the top of our minds as we move forward.
I see that there is a MMWR that was just released today. It just got sent out, so I'm reading it now. It's, I think it's a comment that says California's COVID messaging has been very aggressive, that the pandemic isn't over, and that many cities until just recently still required masks, so that may have been impacting maybe the differences in utilization. Thank you for that comment.
Okay, wonderful, short and sweet. So we will wrap with that. Again, I just want to send a special thank you to both Sarah and Brandon for your presentations today. I want to thank everyone that participated in joining us today. We really appreciate you being here, and we'll see you next time.